Morning everyone. Today my topic is about bleeding disorders. So these are the topics which are covered under bleeding disorders. One is normal hemostasis, vascular disorders, platelet disorders, in which it includes ITP and hemophilias. So what is hemostasis? Hemostasis is derived from the Greek word which means he means blood and stasis means to halt. So basically hemostasis, it is defined as stoppage of bleeding by fibrin clot plugging. So it is normally a natural physiological response in which when there is injury to the vessel wall, there is formation of early hemostatic response, platelet plug, platelet aggregation, and formation of fibrin clot and ultimately fibrinolysis. So this is a diagrammatic representation of how the platelet plug is formed and stoppage of bleeding. So first there is reflex vasoconstriction, in which the arterioles will constrict immediately when there is injury to the endothelium. But this is a very transient process. It usually stands only for few minutes. And next step is about the primary hemostasis or primary platelet plug formation, in which when there is endothelial injury, the subendothelial collagen will be exposed. And when the subendothelial collagen is exposed, there is platelet adhesion with the help of von Willebrand factor, which is attached to the subendothelial collagen. So once the platelet is adhered to the subendothelial collagen, there will be aggregation response in which more platelets are called for and they together form a whole hemostatic plug. But this is also only a temporary mechanism. It lasts for few hours. The next step is secondary hemostasis, in which there is cementing of the platelets together by fibrin material. So whenever there is platelet aggregation, the fibrin material will come into play and it will adhere and strongly bind all the platelets together, as you can see in this picture. That will form a perfect and long-standing hemostatic plug. So this step is called as secondary hemostasis. And finally, there is fibrinolytic pathway activation, in which there is dissolution of the fibrin material. So this is a structure of a platelet. Here you can see there are many different components in the platelets. So platelets are basically acellular organelles which are formed in the bone marrow and released from the bone marrow. Its precursor is called as megakaryocyte, which is present in the bone marrow. So the megakaryocytes, they release the platelets into the peripheral blood. So these platelets are composed of dense granules, calcium, ATP and hydrotryptin, actin, myosin, alpha granules, which are important for hemostatic plug formation. So this is a picture which is showing platelet adhesion and aggregation. So whenever there is injury to the endothelium, so this is the endothelial lining and this is the subendothelial collagen. So whenever the subendothelial collagen is exposed either due to endothelial injury, necrosis or any trauma, the von Willebrand factor will be exposed and the platelets get activated and they bind to the von Willebrand factor with the help of protein called as glycoprotein called as GP1B. So with this help, the platelets will bind to the von Willebrand factor. This step is called as platelet adhesion. And the next is aggregation. Here you can see with the help of GP2B3A complex, the platelets will attach together with the help of this complex and with the help of fibrinogen. So this complex is called as platelet aggregation. So the two steps, adhesion and aggregation, is important for formation of a primary hemostatic plug. Whenever there is deficiency of any of these factors, it will lead to disease which is called bleeding disorder. And when the von Willebrand factor is deficient, it will lead to von Willebrand disease. If GP1B complex is deficient, it leads to Bernard-Sallier syndrome, which is a hereditary cause. And the GP2B3A complex is deficient, it leads to Glanzmann thrombasthenia. So these all are inherited or hereditary diseases. So this is a coagulation pathway picture showing the intrinsic pathway and extrinsic pathway. This coagulation pathway gets activated whenever there is after the primary hemostatic plug response. So in the extrinsic factor, whenever the tissue is disrupted, the tissue factor is released, and this tissue factor will activate factor 7 to 7A. So 7A is the activated form of factor 7. So this factor 7A activated form will further lead to activation of 10 to 10A. Next, prothrombin to thrombin. Then fibrinogen is converted to fibrin. The fibrin monomers will be formed, which ultimately leads to cross-linking of fibrin with the help of factor 13. So altogether, this will be responsible for the primary hemostatic plug and secondary hemostatic plug formation. So this is extrinsic factor. In intrinsic factor, whenever there is injury to the blood vessels, factor 12 gets activated. Then it will lead to activation of series of steps, which is activation of 11, 9, 8 and ultimately 10 to 10A. So this is called as intrinsic pathway, and this is the common pathway. So this is a whole summary. Whenever there is vessel wall injury, the collagen will get exposed and it will activate the platelets. The platelets will get adhered to the subendothelial collagen with the help of von Willebrand factor and GP1B complex. So that is called as platelet adhesion. Next is platelet activation. The platelets will change the shape to sea urchin type of spiky change, and then there is granule secretion from the platelets and activation of 2B3A complex. This will ultimately cause activation of thromboxane A2 and ADP, which will form platelet aggregation with the ultimate formation of primary hemostatic plug. So, and the other temporary mechanism is vasoconstriction, which is very transient effect. It will cause reduced blood flow and primary hemostatic plug response. This is extrinsic pathway activation. Simultaneously, when the platelets are getting activated, the tissue factor also gets activated, and this leads to coagulation cascade, thrombin formation, fibrin polymers formation, and ultimately cementing together of the platelets, which will cause stable hemostatic plug to stop the bleeding. So what are the tests done for hemostasis? The basic tests are bleeding time, clotting time, prothrombin time, activated partial thromboplastin time, and platelet count. These are the basic tests which we use for any hemostatic response. There are few special tests also which we use only when there is any discrepancies or any other known factor cause. So coming to prothrombin time, it is done to assess the extrinsic pathway and common coagulation pathways. So here, exogenous tissue thromboplastin is added with the help of calcium ions. Then clotting of plasma is seen, which is measured in seconds. So what are the causes for prolonged prothrombin time? Any factor deficiencies will cause prolongation of this prothrombin time. Those are factor 5, 7, 10, prothrombin and fibrinogen. So these all factors are involved in the extrinsic and common coagulation pathways. Next important test is activated partial thromboplastin time. Here it is used to assess the intrinsic and common coagulation pathways. So the procedure is we have to add kaolin, that is which acts as factor 12, and cephalin and calcium ions, and C for the clotting of plasma. So when the prothrombin activated prothrombin partial thromboplastin time is prolonged, whenever the factors which are involved in the intrinsic and common coagulation pathways are deficient, those all will cause prolongation of APTT. So those are factor 5, 7, 11, 10, 9 and 12, prothrombin and fibrinogen. So what are the classification of disorders? These are divided into bleeding disorders and clotting disorders. So bleeding disorders, it can be either due to any vessel wall abnormalities or platelet disorders, and clotting time and clotting disorders are mainly because of the coagulation cascade factor deficiencies. So most of these are congenital, and acquired clotting disorders are mainly due to vitamin K deficiencies, fibrinolytic disorders and drug induced. So coming to bleeding due to vascular abnormalities, the bleeding due to vessel wall abnormalities, they clinically resemble bleeding due to platelet abnormalities. So clinically we cannot differentiate whether the bleeding is due to vessel wall or platelets. So the causes can be any capillary endothelial damage, defects in the subendothelial matrix, or any connective tissue defects. So these are again divided into inherited and acquired disorders. In inherited, those are mainly because of connective tissue disorders like Ehlers-Danlos syndrome and hereditary hemorrhagic telangiectasias. In acquired, they are Phenytoin purpura, scurvy, any drug reactions, or cryoglobulinemias. So what are the characteristics of vascular bleeding? It can be in the form of petechiae, ecchymosis, mucosal bleeding, or spontaneous bleeding from small vessels, but the bleeding is very minimal, and for the test for hemostasis are all normal except for there is mild prolongation of the bleeding time. So extensive clinical examination and lab tests are needed to differentiate bleeding from platelet disorders because the treatment for both the conditions is different and clinically they look similar. So here these are the pictures of how the patient is presenting. That is, this is in the oral mucosa, petechiae, this is purpurae on the lips, and this is the ecchymosis on the hard palate. This is also ecchymosis. These are the petechiae. This is allergic purpura. You can see all the reddish spots, bleeding disorders due to any vessel wall abnormalities. Next, coming to disorders due to platelet abnormalities. These are characterized by superficial bleeding like petechiae and purpurae. The thrombocytopenia is present, that is less than 20,000 of the platelet count. Normal platelet count is 1.5 to 4.5 lakhs. So bleeding manifestations occur only when thrombocytopenia, that is platelets, are present below 20,000 per ml. So these are associated with prolonged bleeding time and spontaneous bleeding. Most common sites are skin, mucous membrane, GIT, and the most dreaded complication is intracranial hemorrhage. So classification of platelet disorders, they are divided into quantitative and qualitative. In quantitative, it is mostly the count of the platelets. So it can be thrombocytopenia or thrombocytosis. In thrombocytopenia, the most common cause is immune thrombocytopenic purpura and thrombotic thrombocytopenic purpura. In thrombocytosis, it can be a benign or reactive process or any myeloproliferative disorders. In qualitative, congenital, the most common cause are Glanzmann thrombasthenia, Bernard-Sollius syndrome, and storage pool deficiencies. In acquired, it can be either because of any drugs, leukemias, or any hemorrhagic manifestations. So what is thrombocytopenia? It is decrease in the platelet count below 1,50,000, but bleeding occurs only when the platelet count is less than 20,000. That will lead to spontaneous bleeding. So when thrombocytopenia is isolated, that is only platelets are decreased while all the parameters are normal, then PT and PAPTT are also normal. Coming to immune thrombocytopenic purpura, this is an autoimmune mediated immunological disease which are characterized by destruction of the platelets with normal or increased number of megakaryocytes in the bone marrow. So these megakaryocytes, these are the precursor cells which are present in the bone marrow. So lifespan of platelets, normally there are 7 to 10 days, but in immune thrombocytopenia, here the platelet count lifespan is decreased to less than 1 hour. So there is complete destruction of platelets in the peripheral blood. So the antibodies, they are formed against GP2B3A complex, and based on the duration, ITP is classified into acute and chronic. So acute, it is mostly seen in children and they will have a preceding history of any viral infections, and there is spontaneous resolution in 2 months. It is self-limited. Whereas chronic, it is mostly seen in adults. The pathogenesis or etiological factors are mostly unknown. So previously it was called as idiopathic thrombocytopenic purpura because the underlying cause was not known, but now they have changed it into immune thrombocytopenic purpura because there is an underlying autoimmune mediated destruction, and chronic because it is more than 6 months duration. So acute and chronic ITPs. In acute ITP, there is formation of immune complexes against any viral antigens and formation of antigen antibody complex. These antigen antibody complex, they will cross react with platelets and lead to their immunological destruction. In chronic ITP, there is antiplatelet autoantibodies formed which are directed against platelet glycoproteins, mostly GP2B3A, and they interfere with their function. So this is a pathogenesis. Here there is a platelet autoantigen is formed, which is presented by antigen presenting cell. This will activate the autoreactive T cell, and that will activate B cell. The B cell will release antibodies. These antiplatelet antibodies will be directed against the platelets GP2B3A complex, and this complex is destroyed by the macrophages, mostly in the spleen. So in ITPs, there is patient will be improved by splenectomy. So clinical features, it can be in the form of epistaxis, hematuria, bleeding in GIT, and the major complication is intracranial hemorrhage. What are the lab investigations? These are platelets by manual count on peripheral smear, and the blood film shows occasional platelets which are often large in size, and bone marrow. When we do bone marrow aspiration, there will be increased number of megakaryocytes, and demonstration of antiplatelet IgG antibodies, ultimate diagnostic test. Spleen will be normal in size, and test for hemostasis, there is only prolonged bleeding time. So this is a peripheral smear showing RBCs, and these are the platelets which are almost the size of RBC. So these are called as giant platelets. On bone marrow aspiration, you can see this is a megakaryocyte which is multinucleated, multi-lobe nucleus with abundant cytoplasm. But in ITP, you can see it is reduced. With these are called dwarf megakaryocytes which are hypolobated. So this is a feature of ITP in bone marrow. So the pathogenesis for DTP is because of deficiency of ADAMTS13, which is a plasma enzyme which degrades the multimers of von Willebrand factor. So here normally the ADAMTS13 will cleave the von Willebrand factor into unfold this and activate the von Willebrand factor. But when there is absent of ADAMTS13 enzyme, the von Willebrand factor will be present in the multimeric form, which will become inactive and cause the deficiency of the bleeding. So clinical features, it has a pentad or fever, transient neurological deficit, renal failure, microangiopathic hemolytic anemias, thrombocytopenias. The spleen may be palpable. So lab diagnosis on peripheral smear, they will show schistocytes like broken RBCs. These are called schistocytes, which are characteristic feature for DTPs.